Hi, this is Dr. John Bennett. I'm the head of Neurosurgical TV.
Thank you, Dr. Bennett. I'm Simon Downs, creator of usicko.com. Dr. Ko is an innovator. Let's hear her speak.
This painting is now on display at the UNESCO headquarters in Paris. And the idea behind this painting is that the brain is still amidst a atmosphere of chaos. And what Nadia was saying was very interesting because for me, she defined the journey from idea to innovation. And at the heart of innovation is creativity. And I am of the mind that creativity can pretty much solve all problems. And I favor creativity over any physical aggression in solving any problem. I consider creativity to be one of my best tools. In fact, almost as important as the scalpel or the rongeur in applying it both in the art studio and in the operating room. When I was part of the Cornell system, I was stationed at a level 1 trauma center in the Bronx called St. Barnabas Hospital. And I think Susan Panulo was incarcerated here with me for about a year and a half. And when the Cornell system pulled out, I stayed on 5 years as the chief of neurosurgery here. And of course, at a level 1 trauma center in the Bronx, you see a lot of head injury and all sorts of emergencies in the middle of the night. And one of the things that I started focusing on, because I was taught to treat head trauma, severe head trauma with decompressive craniectomies. And so you do the decompressive craniectomy, monitor the patient, ICP Lycox in the neurosurgery ICU. And, you know, when you did the decompressive craniectomy, what would you do with the bone flap? And so this is an example on the left of a person who, and I didn't operate on this person, but he was referred to my clinic and he ended up having, a frontal craniectomy. The bone flap was not available. And so the idea was to somehow rebuild his calvario contour and also provide protection for the underlying brain. And so he was going to eventually be scheduled for a cranioplasty. But when you do a decompressive craniectomy, you either have to, as you know, put the bone flap somewhere. So some of us put it in the subcutaneous tissue. If you have access to a specialized refrigerating system, you can put the bone flap there. If not, you end up having to go back and do what we call a cranioplasty. Sometimes some of the options are titanium mesh and methylmethacrylate. Sometimes if the patient has the right insurance, you can order a prefabricated 3D printed skull implant. My patients at St. Barnabas Hospital had none of these. They didn't have the resources to order that. So I ended up doing a lot of cranioplasties with titanium mesh and methylmethacrylate. The problem with going back a second time after the patient has made a recovery, now this is 4 weeks, the patient has come out of the ICU, gone to rehab, 4 weeks down the line, comes back, brain swelling is gone. And you can see that the scalp here is sunken. And so what do we do here? And we bring the patient back to do a cranioplasty and the entire incision has to be reopened. This is a very large trauma flap. And patient has to go under general anesthesia. The operation takes, 2 to 3 hours. It's a straightforward operation, but it's not without its hazards. You have to separate the galea from the dura, sometimes not easy. You don't want to risk any further brain injury. And so, just one of the things, this is one of the ways that I would use it. And so I would put a, titanium mesh over the dural surface and then buttress that with methylmethacrylate, then reclose the wound and put the patient back in the ICU, get a post-op scan. But here's a short video on that actual procedure.
Never know how much I love you. Never know how much I care. makes me fever when you hold me tight.
That's basically the procedure. And so I got to thinking, when I was doing surgery one day after doing about 100 of these or more, way more. And I was thinking, is there a better way to do that? Is there possibly an alternative way? Can we keep the bone flap in place somehow? Do the sort of a decompressive craniectomy, but keeping the bone flap there, allowing for brain swelling. Why we do decompressive craniectomies is to increase the intracranial volume. And can we do it but not subject the patient to a certain operation? And one of the benefits of working in a private hospital that doesn't have the hierarchy of a university is that you know the IRB committee. You don't have to stand in line between 100 in back of 100 projects. You can get your projects heard pretty early. You get good feedback. And so they passed the IRB for me to do what I call a hinge craniectomy. So this is my painting of the hinge craniectomy. And as you can see, the periosteal is pushing the scalp flap back. This is the micro screwdriver, the bone flap, and I am screwing in a micro plate here, down here. This would be the hinge section, and this is the area where the bone flap would float up when the brain swelled to accommodate brain swelling. And so these two plates would be left unsecured. I wouldn't put these plates and secure the bone flap to the skull. I'd leave them open, but the hinge would be down here. And this is actually a 3D CT recon of the hinge in situ. And you can see the patient is intubated. Most of them would have ventricular drainage of CSF, ICP monitoring, and Lycox. But here is the actual hinge. You see the microplates down here. The bone flap is attached to the skull. This is the unattached, free microplate on the bone flap. And you can see there's quite a bit of excursion of the bone flap off the skull to accommodate brain swelling, help alleviate ICP also. So the what I would do after the brain, after a period of time, the patient's in the ICU, ICP is normalizing, the brain is coming down, the patient has actually gone to rehab, and I would offer them to come back and have the hinge closed. And so in the beginning, these are the two plates that are secured at the bottom. This is kind of the hinge area. This is the unsecured bone flap up here. So I would use fluoroscopy to identify the microplates that needed to be screwed in. And you can see how small my incision is. It's 50, basically 5 staples. So I would use this plate that's already there and put a screw here and put it through the calvarium so that the hinge was closed. This is my drawing of the closing of the hinge, and I called it a modified cranioplasty because there wasn't a code for it. But you can see how small the incision is. I had the honor of doing this procedure on a high-ranking police official, and when he came back for the hinge closure, it was 15 minutes under local. So instead of doing a large cranioplasty opening the trauma flap, it was 15 minutes under local. He spent an hour in the recovery unit and went home. Afterwards, I stopped using fluoroscopy because I've done over 100 of these, and along with some of my colleagues that I've worked with, they've also done it. And in other countries, I stopped using fluoroscopy, and I would just mark the area where the plate is, the unsecured plate is with a staple, and so I just reopened that area. This will be a short video on that procedure. Okay, this is the hinge, a bifrontal hinge. You can see the excursion. This is the actual hinge craniectomy. Look how far that bone flap is able to move out. I did a lot of work with plastic surgeons. This is a traditional cranioplasty, big difference in size. So it affords less anesthesia, in fact no anesthesia, and no real return to the OR. It's useful for stroke and some traumatic brain injury. Not all patients qualify. You can avoid implanting it in the subcutaneous tissue of the bone flap. You keep the bone flap in situ. You don't need refrigeration. And the second operation, even to close the hinge, may not be necessary. I found out in a few. I never had a skin breakdown. I did a lot of work with plastic surgeons, so I understand pretty well. They taught me a lot about how the scalp can actually expand quite a bit to accommodate the movement of that bone flap outward. And I never had to convert a hinge craniectomy to an actual craniectomy. So it's a judgment call during surgery. Not all patients qualify, but at this point, there's over hundreds done. I wrote an article for Neurosurgery called the In Situ Hinge Craniectomy. About 2 months later, on the cover of JNS was an article by Dr. Smith, and he titled his procedure the hinge craniotomy. I called it the hinge craniectomy because in my mind it was an adjunct to decompressive craniectomy. He's been every time he gets credited with originating this procedure, he's very kind in mentioning my name and saying, no, Dr. Ko did it also. So I appreciate that. I think that's the highest form of collegiality. And I went on to patent the procedure after that. It was a very long process from the idea in the operating room to actually having the patent done. Well, at that trauma center, the private trauma center in the Bronx, there were no neurosurgery residents. So my physician assistant here, and by the way, she worked with me for over 15 years. She came with me through 3 hospitals, and I attribute most of the success I've had in my career to her. It was just a partnership that you wait your whole career for. But anyway, she would leave around 6 o'clock and she wasn't there on the weekends. And so who would cover the neurosurgery service were first-year surgery residents who had very little experience, or ER residents. So there were a lot of phone calls at night, kind of unnecessary. The communication wasn't that great. There was a lot of unnecessary trips to the hospital in the middle of the night because things weren't really clear. So I went before the IRB committee and I said, can I put a web camera secured in the ICU, so that one ICU room, so that I can see the patients. I have online visual access to what's going on. And the IRB committee passed it. Of course, we had consents for the patients. No patient or their family ever declined being involved in this project. But this is my drawing of the camera. And I tell you, the year was about 2008. So the camera at that time was very, very expensive. Every single bit of research that I have ever done, from the holograms to this BC&U, I called it BC&U because I was seeing them. From the holograms to the camera, I paid for myself right out of my pocket. I never got any funding. I never got any grant, and I would do it again in a heartbeat. So I asked the IRB committee. I gave them this legend, the physician assistant, the patient, myself, telemetry, and the webcam. Here's the webcam. Now the webcam, this camera was so sophisticated back in 2008, and the optical zoom was incredible. My hobby is technology, and so I was really into it. You could see the expiration date on the medication hanging from this IV pole. That's how good it was. The camera had 360 rotation and pan and tilt capabilities, and of course you could control it robotically. So I would look at the telemetry, check the ICP, check the Lycox, check all the parameters, look at the patient, do a wound check. You could even look around the room, who was in there, what the nursing staff, and it was quite a really impressive ability to have clarity when you weren't that comfortable with the in-house staff, not because they weren't good or they weren't trying, they just weren't experienced. And so it gave you that extra level of comfort. And this is how long ago that project was, is because here's a BlackBerry, right? It's almost an antique, able to dial up the patient on the road, looking through the BlackBerry, and then move the camera robotically and look at the vital sign parameters, the intracranial pressure and everything, give you a level of comfort and security that was unmatched by a phone call. And over the period of 4 years, I was able to divert or avert certain issues from becoming really problematic. Here's one case I did middle of the night, called the resident in the morning. It was an ER resident rotator. And I said, how's the patient doing? Oh, patient's fine. Everything's fine. Oh, really? Everything's good. I dial up the camera, look at the patient, and then the patient turns and, okay, he's not fine. Nothing happened. We were able to get the situation rapidly under control. There was no issue. He did fine. But it gave me the ability to double check what I was being told. And so I went back to the resident. I said, I think we better go back in that room because I got another assessment on the camera. So it's really, really an amazing project that helped me manage a level 1 trauma center without any neurosurgery residents and only some rotators. I was able to present this data, this whole project, because I had been 4 years into it. And my title was Telemonitoring of Neurosurgical Patients, 4 years experience. This was at the ANS conference 2013. And the theme of the conference was patient safety. So I thought, okay, patient safety, it's a real good match. But I guess the organizers and maybe even the president, Dr. Berger, didn't feel that it was such a good match because I got the last talk of the last day. And so here's my cartoon about that conference. Day 1, the conference is really lively. Everybody's there. Day 2, it's starting to wane. And day 3, this is me. There was actually, when I gave my talk, the last talk of the last day, I was in a conference room that seated about 2,000 people, and there were literally 4 people there. And at one point when I gave my talk, I actually thought I had a question, but it was actually my echo coming back at me. That room was so big and cavernous, there was just nobody there. And by the time I finished my talk, even the moderator, who was one of the future presidents of the ANS, Shelley Timmons, was gone. So I was the only one on the stage, and there were very few people in the room. And so I kind of felt like, I had a really good idea. It was a great project. It meant so much to me, but maybe nobody, appreciated it. I've had a ton of ideas in my career, and some of them were just failures. But I thought this one was pretty good. And, sometimes you feel kind of lost and alone when you put out an idea or you put out a project, and, you're sort of wandering down in the cisterns. You don't know which way to go. Should I go at that branch in the artery? Do I go right or left? But, sometimes the time for that appreciation for that project it's too early. And so my philosophy after this and similar episodes, similar projects, was to just say, just throw it, just do the project, do the work, enjoy the process, learn from it for your own career, use your own creativity and develop your own ideas, and then just throw it out to the universe. It doesn't matter if nobody appreciates it. But then, and that was 2013, but then, a pandemic came, and in 2020, everybody's talking about telemedicine, teleradiology, telemonitoring. And now I finally feel confident enough to put those 4 years of work into a publication. And so I'm working on finally putting that out now. So like I said, one of my ideas is when I use my creativity to, in the art studio, in the operating room, to just, present the idea, take it as far as you can. Sometimes they don't, hardly any of them end up in a patent, but to move on, to keep innovating and keep creating and keep moving forward.